Oral candidiasis is the most common fungal infection of the oral cavity, mostly caused by Candida albicans as one of the normal microflora organisms. It can be isolated from almost 50% of dentate patients and more than 60% edentulous individuals with with a female predilection. The aqueous pseudomembranous form of oral candidiasis is usually seen in infants due to their underdeveloped immune system. The elderly patients are also predisposing for this type of lesions. It's very easy to rub off this oral thrush. It is very characteristic for young adults, so as we said, newborns, older patients, and also patients with immunocompromised, so patients with AIDS. Creamy white plaques, patches on papules that can be wiped off with erythematose bottom. Classic appearance of pseudomembranous candidiasis is called like curdled milk. Burning sensations and foul taste might accompany but the lesion also as well. What is the diagnosis? How do we do the diagnosis? How do we diagnose the pseudomembranous candidiasis? We do a smear, so cytology, swabs, culture of saliva or saline rinses, biopsies. We also like to ask patient about the full body picture or liver function tests. Sometimes also we ask about the iron and ferritin and folate or vitamin B12 and also we ask about the immunological and endocrinological disorders. The next disease, which is very popular in our department, is oral lichen planus. It is defined as common chronic mucocutaneous disease with unknown etiology. Oral lichen planus involves 0.1 to 2.2% of general population and mostly arises after middle age with a mean age of 55 years. Women are affected more frequently than men with a female, the ratio 3 to 2. Cutaneous lesion can be detected in approximately 15% of patients, although the etiology is multifactorial. Imbalanced immune system with the presence of autoreactive T lymphocytes plays a principal role in the evolution of the disease. Other factors such as stress have also been noticed in the development of its inflammatory process. White components might be seen as papules, plaques, and also reticular areas. The most common form is reticular form. It's often mixed with reticular form and also papular form. You see here the clinical pictures when we have the oral lichen planus on the mucosa. We have those 6 various clinical manifestations. So papular, most common, reticular, plaque-like, bullous, erythematose, and ulcerative form. Some systemic diseases and medical conditions copy the same clinical appearance as the RLP. So it can be lichenoid reactions, and also it can be also Greenspan syndrome, and RLP also shows up as a part of the Greenspan syndrome. So it is diabetes, and also it's hypertension, often diagnosed with this type of disease. And lichenoid contact reactions, so very similar reactions related to the local factors. So lichenoid contact reactions are considered to be a delayed hypersensitivity reaction to constituents derived from dental materials. Since the majority of patients show a positive patch test to mercury, it is considered an allergic reaction. Nearly all dental restorative materials, except for precious metals such as titanium, palladium, and zirconium, might give rise to lichenoid contact reactions. And also drug-induced lichenoid reactions are related to delayed hypersensitivity reaction. It has been suggested that drugs or their metabolites precipitate to the lichenoid reactions. And that's why it is advised that even when the patient had like 30 years the amalgam filling, or for 30 years they had some denture, And we all know that those lesions, they should be evacuated from the oral cavity because of this. When we have some lesions on the membrane mucus. Okay. Mm-hmm. And leukoplakia. Also, leukoplakia is the next white lesion, which is quite common in the oral cavity. When we find dysplasia in the leukoplakia, we treat it as a precancerous state. The definition is pretty old, and it is pretty non-specific because it's any white lesion which cannot be qualified by any by a different into a different category. So the prevalence of the oral leukoplakia is reported to 2.6 among general population. So we can say that not as often, but among our patients, it is quite often. There is a predilection for development of to the squamous carcinoma, especially when the location is on the bottom of the mouth, of the floor of the mouth, and also on the sides of the tongue. The different type of leukoplakia is the hairy leukoplakia, and this lesion is related to the Epstein-Barr virus infection, and also it reaches it's found among the immunocompromised patients, so patients with HIV, with EBV infection, and also during, for instance, the oncological treatment. Oral hairy leukoplakia is the second most common HIV-associated oral mucosal lesion. Has been used as a marker of disease activity since the lesion is associated with low CD4 lymphocyte counts. It is caused by concurrent infection with the Epstein-Barr virus. The lesion is strongly associated with HIV disease, but other states of immune deficiency, such as those caused by immunosuppressive drugs and cancer chemotherapy, have also been associated with OHL. Appears to be the EBV induced lesion in patients with low levels of CD4 T lymphocytes. Antiviral medication which prevents EBV replication is curative and lends further support to EBV as an etiologic factor. There is also a correlation between EBV replication and decrease in the number of CD1 or a Langerhans cells, which together with T lymphocytes are important cell population in the cellular immune defense of the oral mucosa. Aphthous ulcers, so popularly named canker sores. Yes, these are quite common lesions, especially the lesions which are minor, so minor aphthous ulcers, so the Mycolitis aphta. And also major aphthous ulcers, so Beckett's ulcers, and herpetiform aphthous ulcers. So those are the three types of the aphthous ulcers. You have here located the minor salivary minor aphthous ulcers. These are the major aphthous ulcers, so the Beckett's ulcers, and these are the herpetiforms. They're quite plural. The present studies show that confirm that the crucial role of the immunologic disturbances of the etiopathogenesis of RAS, so the genetic predisposition, viral and bacterial infections, and also based on many studies, results recurrent after appear more frequently in patients with gastrointestinal disturbances, mainly those from the group of chronic inflammatory bowel disease, so Crohn's disease, ulcerative colitis, and celiac disease. Food allergies, according to some researchers, also are the exposition to some food ingredients, so chocolate, gluten, cow milk, preservatives, nuts, and food coloring agents may also induce the pro-inflammatory cascade and aphthostomatitis development. Some vitamin and microelement deficiencies in some patients with RAS also can be the reason, and some systemic diseases like celiac disease, Crohn's disease, ulcerative colitis, and also AIDS. So remember that the reason of the development of AFTA with each person can be different. For me, for instance, it can be the lack of iron, right, or the iron deficiency. For you colleagues, it can be a deficiency of folic acid, or for somebody else, it can be the increased number of the T cells or decreased number of the CD4 lymphocytes, right? So there's always after ulcer are the basically are the symptom, and the reason of it if it's immunity. And sometimes also the local causes, so the local irritant plus the immunity, right? Usually the small after ulcers, they are healed after 10 to 14 days. But the problem is with the Beckett's afta, so the big afta, which usually is very painful, and it's related with the different diseases. Different rheumatoid and dermatological diseases, and it's not so easy to heal the lesion. The next part of the lesions will be the quite common lesions. Usually they are ulcerations, and the ulcerations can be traumatic. As you can see on this picture, this is a young child, history of a young child who did not follow this what was indicated. After the procedure, we informed about not eating for 2 hours, and the kid was unsupervised, and the kid was playing with the membrane mucus and chewing basically on it. And the patients came very upset and very worried about this, that something grew on the lower lip of this young boy. And this was, of course, the trophic ulceration, basically a chewing wound. It's not healing so well. Usually there is a big bruise, there is edema, and it's painful, but it's related with the chewing after the chewing and playing with the membrane mucus after the anesthesia. Here we have also different lesions in the oral cavity. Those lesions are already oral cancers. And the lesions on the tongue. I would like to show you the different lesions which can be located on the tongue. The upper left will be the benign inflammation of the tongue. So it's a geographic tongue. The lower one also is a geographic tongue. When we're not sure of the diagnosis, we advise for the patient to take a picture of these lesions every 1 week, and we'll collect approximately 6-7 pictures, and we see these lesions, they migrate, right? We have some local hyperkeratosis, and also some bold places when we do not have basically the papillas. And here is the overgrowth of the papillas due to the local irritation. Usually there are some lozenges, or there is some alcohol, or also smoking. And here on the side of the tongue, we have a lesion type of tuxa, so eosinophilic traumatic ulcer related with some irritation. HPV infections, so also quite common infections, which can be white or pink, depends on how long do they say, where are they located in the oral cavity. They're related with the infection of the HPV. Some subclinical infections, so the majority of the HPV infections are subclinical and cleared within 1 to 2 years automatically by the organism and without any manifestations. But some manifest. The question is why they manifest, when they manifest, and why they manifest in this place. When they manifest in this place, we can also think about it, that there is some traumatic history of this place. In oral cavity, we have many places when we can accidentally chew or hurt. That's why patients can have the verruca vulgaris. And also, when does it happen? We don't know this, but it's related with the immunity. And why in some people this system of the defense works and in some people doesn't. We need some still more research about that. So the lesions which can develop after the HPV infections are verruca vulgaris, so the most popular, usually related with the HPV number 1, number 2. Squamous papillomas are characterized by exophytic projections described as finger-like or cauliflower-like warty areas, and focal epithelial hyperplasia, so HEX disease. It's usually 32. HPV and NPV infections in oral cancers, usually 16 and 18. There is a strong correlation between the 16 and 18 with the uterus cancer, but also it's found in some lesions in the oral cavity. The viruses may be spread vertically from mother to offspring or horizontally between individuals. And please remember, I would like you to know it and to spread it among your patients, because they will ask you if it's contagious when they have this type of lesions. Diagnose, yes, it is contagious, but we know that this virus lives in epithelium, right? And this is we have the epitheliotrophism, right? So it's predilected to the epithelium. That's why it's very easy, it's very contagious, it's very easy to get it, because basically, like in the past, we thought about it that it's transmitted just through, it's a sexually transmitted disease. No, it's not just a sexually transmitted disease. It's also disease transmitted by a touch, by contact with a different person, meaning the contact with the epithelium. So you can get it at the during the manicure, during the pedicure. You can get it during the haircut. You can get it on the swimming pool, and you can get it also in the restaurant. So it's difficult. It's very difficult to prove where did I get the HPV, because some patients are keep asking these questions. We don't know when and where they got it. It's impossible to find out by now. Here you have a clinical picture of a patient who has the pleural lesions on the palate, and it's called papillomatosis of the palate. It's related with the HPV infection. Usually, these are the benign types, but usually with edentulous ridges, we have this type of infections. Okay, and here we have a single infection on the located on the tongue. And here we have a Hex disease. Hex disease, so we have the lesions which are the same color as the rest of the membrane mucus. And this Hex disease, we have pleural exophytic lesions in different areas of the oral cavities. They are prone for traumas, and they should be removed if they are irritated. And this is a typical, very characteristic cauliflower-like lesion, typical for the HPV infection. And the lesion which we would like to diagnose, at least, we would like it to be less common than it is now, but it becomes unfortunately more common now. And the predilecting factors for the oral cancer is smoking, local trauma, so any local trauma related to the unfitted denture, to the overhanging fillings, to the calculus. HPV infection, also EBV infection, some fungal infections, and some also immunosuppression. Sometimes we need just one trigger, sometimes the couple triggers, and then in some time they're usually long lasting. And then we have the development of the oral cancer. Oral cancer used to be characteristic for older people, but not anymore. We have younger and younger population patients which are coming to us, and also we diagnose cancers. Some lesions are very fresh, and some lesions are older. And here we have 4 clinical cases of the oral cancer. The upper one is the Pool's syndrome, and it's located in diastema between the upper incisors. This one is pretty small, and it looked kind of benign, but unfortunately it became the oral cancer type 2. It was related with the unfitted denture. And this is the bottom of the tongue, and this is the alveolar ridge. And thank you for your time and attention. That will be it with regard to the white lesions. Are you still there? Are you sleeping? Did you fall asleep? Hopefully no. Are you there, guys?
Yes.
Yes, okay, you didn't fall asleep. I'm glad you didn't fall asleep. Okay, now we'll speak a little bit about the mixed and red lesions in the oral cavity. So you have more information about this. Just a moment. I will open the new presentation. Oh, Okay. Okay, so I would like to tell you about the desquamatic gingivitis. Sorry, I'm yawning. About the desquamatic gingivitis. It's not a separate type of inflammation. It is always related to the general disease. So desquamatic gingivitis, when you see it clinically, when you think about it clinically, you always have to think about the general disease. So it's related most often with the autolicum planus, mucous membrane pemphigoid, or the pemphigus. So those are the three most common related diseases with this unit. And when you think about desquamatic gingivitis, first you need to diagnose the patient, so you need to do the biopsy. The best region to do the biopsy is gingiva, but we take part of the healthy tissue and part of the unhealthy tissue, and we examine it. So we can do the normal histopathological examination, plus also some, when we suspect some pemphigus and pemphigoid, we should do some immunofluorescence. Okay. This you have here the desquamatic gingivitis related to the lichen planus. And we have the hyperkeratosis, hemichronic inflammation. So we have the infiltrations of lymphocytes, plasma cells, eosinophiles, and also inflammation around blood vessels. When we speak about the red lesions, we should think also about the radiation mucositis, about any mucositis. Mucositis is related to the chemotherapy and radiotherapy. Now we have, of course, in our department, we have many patients who are who have oncological history, or are during or after the chemotherapy and radiotherapy. Sometimes they take the pills. Sometimes they have to go to the hospital for the chemotherapy or radiotherapy, but they can develop the mucositis. And also the mucositis is we have 4 stages of it, and it's related first. It can be noticed as dryness and also thinning of the membrane mucus, and then we can have some painful erosions and ulcerations, and then it can worsen, and the patient may have troubles with drinking, swallowing, and eating, and then sometimes it's very difficult to function. So the patient has to be in coma. With regard to the treatment, so the patient has to avoid any irritants. The patient has to moisture the membrane mucus, and they have to also rinse membrane mucus with the non-acidic solutions like Cafosol. About the geographic tongue, we said that it's now I have some more clinical pictures for you, that we have some red patches which are bold and they are surrounded by the hyperkeratosis. Medium rhomboid glossitis, this is also the rare condition that occurs exclusively on the dorsum of the tongue. There are many theories. There are many theories about this. If it's development, or if it happens during the life, just because we have some immunosuppression. But we all know that oftentimes we have the candida albicans or candida infection on the tongue, and we have medium rhomboid glossitis on the. Usually, it looks like a kite, or just not a kite, maybe, but some round or oval shape lesion on the tongue, and also we have a very like a copy of this lesion on the palate. And usually it's asymptomatic. Sometimes it's a little bit itchy, but it can be, in most cases, it's asymptomatic. We should do a swab, and sometimes you should do a biopsy, but it's always related to a smoking, in most cases, smoking and immunocompromised patients. Some stomatitis after the using the dentures, when the patient is not using the denture in a proper way, so they don't follow the hygiene, and they don't remove it for the night, or they remove it very rarely. They don't clean it well. they can develop the denture stomatitis and the erythematous candidiosis in the oral cavity. This is also the pseudomembranous candidosis, the clinical pictures, and the redness under the denture, which is related to this, that the patient wasn't using it as they should. This is a clinical picture of the squamous cell carcinoma on the palate. Of course, we are not allowed, we shouldn't remove any teeth from it. First, we should examine the lesion, do the biopsy, and then plan the treatment. It should be first surgical treatment, afterwards maybe the radiotherapy and the chemotherapy. Here we have some squamous carcinoma on the side of the tongue and also on the tongue. The lesions sometimes they look quite innocent because we have the endophytic growth. Some is mixed, so exophytic and endophytic growth, but in most cases, when it's neglected for a long time, it's endophytic growth, and the pain occurs very lately. The different the lesion which is considered to be precancerous, secondly most common after leukoplakia, is erythroplakia, and the definition is also not so precise. It's after the Queyrat, so Queyrat erythroplasia. It's a pre-malignant lesion, so any lesion which can be classified as a different lesion, it is erythroplakia. Unfortunately, with erythroplakia, we have a higher tendency for dysplasia than with the leukoplakia. In most cases, when the local irritants are not removed, the oral cancer, squamous cell carcinoma can be noticed in this erythroplakia. Yes, these are the clinical pictures of the buccal mucosa, red lesions, and the squamous cell carcinoma. The plasma cell gingivitis, it is also the rare and unique gingival disorder characterized histopathologic by a dense chronic inflammatory infiltration of the lamina propria, mainly the plasmatic cells. Usually, it's the region is the etiology is unknown, but it's a reaction to the local allergens, chronic infections, and plasma cell crisis have been considered a possible cause. We notice it clinically as some redness, bright redness, and there is a tendency for bleeding. Of course, we have to perform the biopsy for it, and we have to distinguish it with the desquamative gingivitis and candidiosis. And this is a plasma cell gingivitis. And also we have the granulomatous gingivitis, and so desquamative gingivitis as a manifestation of the lichen planus and pemphigoid, right? So these are the clinical pictures of the desquamative gingivitis, and the different red lesion is the linear gingival erythema, and this is the lesion which is characteristic for AIDS, for the HIV. Contact allergic stomatitis, it's a quite common lesion caused by, for instance, acrylic resins, which are from the dentures or from food, or sometimes the toothpaste or mouthwashes. Some bacterial infections, some gonococcal stomatitis and gonococcal erythema, and also hemangiomas. Located in the oral cavities. Of course, with the hemangiomas, usually they are benign and they need to be removed by laser therapy. The next disease which can be found in the oral cavity can be lupus erythematosus. It is a chronic immunological mediated disease, autoimmunological disease, and we have two main forms of the disease which are recognized as discoid and systemic. The oral lesions develop in 15 to 20% of the cases in the discoid form, and 30 to 45 cases of the systemic lupus. After the laboratory testing is the histopathological examinations, and the patient who has systemic lupus erythematosus shows that the band-like accumulation of IgG and along the basement membrane, so the lupus band is positive, and the anti-nuclear bodies in the epidermis. And this is a lesion which is characteristic for the discoid lupus erythematosus on the buccal mucosa. The CREST syndrome is a clinical variant of the scleroderma characterized by a combination of calcinosis cutis, so Raynaud phenomenon, and esophageal dysfunction, sclerodactylia, and telangiectasia. Usually it may occur on lips and oral mucosa. Telangiectasia, hereditary hemorrhagic telangiectasia, or Rando-Osler-Weber syndrome is a rare mucocutaneous disorder characterized by dysplasia of the capillaries and small vessels. And here we have the hereditary hemorrhagic telangiectasia, so multiple lesions on the tongue. Yes, and anemia also, like pernicious anemia, iron deficiency anemia, so Plummer-Vinson syndrome, or the different types of anemia, they manifest in the membrane mucus, so they can be noticeable, and you can be the first doctor who diagnoses the patient with this type of disease. Of course, the pallor of the membrane mucus, and also the tendency for bleeding, and also tendency for traumatization, and the exposed basically nerve endings on the tongue, so the patient has the feeling that there is a irritation of the permanent irritation of the tongue. Here is a clinical patient of the clinical picture of the patient with the history of chronic iron deficiency anemia. So without papilla filiformis, with angular cheilitis, basically the tongue is like bald without any papillas, and it's very exposed to any traumas, and very exposed to foods and drinks, and very hypersensitive with regard to the sensation. And the purpura, we can have different type of purpura related to the anemia, and also thrombocytopenia, and different diseases related to the platelets, and also related to some viral infections like mononucleosis, and Reiter's disease, so diffuse erythema on the palate. It's a differential diagnosis demands for us the Beckett's disease. The treatment is with corticosteroids and anti-inflammatory agents of choice. Here we have a clinical picture of the Reiter's disease, the erythema on superficial erosions of the tongue, and also Struve-Weber's angiomatosis. It's an encephalotrigeminal angiomatosis. It is a relatively rare sporadic congenital capillary vascular malformation, typically involving areas innerved by the trigeminal nerve, and it's developmental. Here we have a Struve-Weber's angiomatosis, so the facial hemangiomas. Yes. And the hemangiomas on the alveolar mucosa, we have to be very careful during the performing the anesthesia with this patient. Okay, so that would be it. I hope you didn't fall asleep. I didn't have as much feedback as I would like from you, but I understand that maybe this is not your time. Yes, maybe you would like to meet in the mornings. But we had to meet during the evening. We have 11 people by now with me, so I believe it's your maximum. So as I mentioned at the beginning, we did all of the stuff today, right? All of the information which I wanted to tell you we had to do during this meeting, because I'm unable to meet you when it's planned, because I'm going for the oral medicine symposium, and I won't be in Poland. If you have any questions, you can feel free to ask me questions. I hope that your oral medicine adventure it's just the beginning, and I hope that you will enjoy it, and I hope that we'll meet during the classes, because we have still the fifth year and both semesters. But even if oral medicine is not your plan for the future, and even if you won't like it as much, please remember about this, what I said at the beginning of today's lecture about the oncological vigilance. So we all have to be responsible for this, for the oncological diagnosis of the patients. It literally takes sometimes just a couple seconds more, and you can save somebody's life. So do you have any questions for me? No, you want to just log out and you want to eat supper, yes, and go to sleep. Okay. So thank you for your attention. Thank you for your time, and maybe we'll see each other. We'll see each other on the UCS corridors. Okay. So thank you. Bye bye.
Thank you. Goodbye.
Bye.